event. Sorry about that. And thank you to our lovely speakers for agreeing to share their experience and understanding as well. We did have over 90 people, as Riley mentioned, asked for the recording for the session. So just want to let everyone know that if needed, a recording will be available afterwards. Before we begin, I'd like to start with the land acknowledgement. So we acknowledge the land we are meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people, is now home to many diverse First Nations, Inuit, and Métis people. We acknowledge that Toronto is covered by Treaty 13 with Mississaugas of the Credit. So you may or may not be aware of the current state the public care system is undergoing. The Ford government is expanding the funding for private for-profit clinics and moving surgeries and diagnostics out of our public hospitals and into for-profit clinics. While at the same time, he is underfunding our hospitals and doing nothing to address the staffing crisis. We have gathered post-secondary students here today in hopes of bringing awareness to the issue, along with informing you in ways in which you could get involved. We believe that this is a matter which is most important to ourselves and the next generation, because it is the future of our healthcare system, which we can face consequences if action is not taken now. So to begin, we will have Natalie Mera joining us. Natalie is the Executive Director of the Ontario Health Coalition. You can go ahead when you're ready, Natalie.
Thanks, Sophia. Thank you for all of the student interns who've been working with us, and Hisham and the Ontario Medical Students Association for everything that you've done to organize for this meeting. I just wanted to, I just don't know if the spotlight is working. It's not for me. Riley? I just wanted to start by telling you, telling you about a little bit about sort of the history of public Medicare in Canada. There was a book called Life Before Medicare. It was done by the Ontario Senior Citizens, Coalition of Senior Citizens Organizations. And they wanted to gather stories from people, from Canadians, about what happened before we had public Medicare, before people who had that experience died, so that people wouldn't take for granted public Medicare in this country. Most people here have no idea how much healthcare costs or what would happen if we were to lose our public Medicare system. But I will never forget some of the stories in that book, and I wanted to share one of them with you. It was the story of a woman, and she was in Saskatchewan. It was a farming family, and she had cancer, and she knew that she was dying, and she didn't want to bankrupt her family or bankrupt the family farm by her medical treatment. And so she told her husband not to seek medical treatment for her. And she had him lock her in the house when he left for the day. And the daughter, as I recall, it was the daughter that wrote out the story and sent it in. And she says that she remembers growing up, hearing her mother scream in pain in the house after having been asked to be locked in so that she wouldn't seek help or seek treatment and ruin her family after her death. Those were the real stories of life before public healthcare in this country. And there is no question that with privatization of our public healthcare, with the privatization of who provides the services, we see an increasing burden of out-of-pocket costs for patients when they need care. So I wanted to make sure that we all understand what we're talking about when we talk about public Medicare. Public Medicare is a system in this country. It's OHIP in Ontario. It's our public insurance plan. It means that we pay for healthcare, like other social services, ahead of time through our taxes. And that care is supposed to be available to us when we need it, when we're sick, when we're elderly, when we're dying. Usually we're unable to work and the most unable that we ever are in our lives to pay for healthcare. And that is how we provide healthcare for everyone. The principles that underlie public Medicare in this country are compassion and equity. The Canada Health Act says that services are to be provided on an equitable basis for all Canadians from coast to coast to coast, regardless of income, ability, and so on, that they're to be provided based on our medical need, not how rich we are. The idea is that services are universal, that judge and janitor would share the same hospital ward. Why? Because then the judges of this world have an interest in having good hospital wards for everyone. The idea is equity. And those people who support privatization at the core of it, don't support that fundamental principle of equity. I always laugh when people say that the opposition to privatization is ideological, because if what they're saying is it's based on values that are deeply held among Canadians, yes, it is. And I, for one, am proud of that. I don't want that to go, because we see the consequences of privatizing healthcare in the United States and around the world. So within the public healthcare system, this system that is paid for by our public taxes and is supposed to be provided to us based on need, we have rules. And the fundamental rules of the Canada Health Act are that you cannot extra bill a patient. So you can't charge OHIP and the patient on top for this service. You're not allowed to charge user fees for medically needed healthcare services. And because the Canada Health Act was written when most services were provided in hospitals and by physicians, it covers hospital and physician services. And so what does that mean? Well, it means that you cannot be charged for a surgery. It's illegal to bill a patient for a medically needed surgery. It's unlawful to bill a patient for a medically needed diagnostic test. So those things are not allowed. And through that mechanism, we preserve the equity of the system. And it's supposed to cover us across the country. If we move from province to province, it's portable. That's one of the principles. So the public insurance system is supposed to cover you. It's supposed to be accessible. It's supposed to be comprehensive. That is, cover a comprehensive range of the services that we need, all of the medically necessary hospital and physician services that we need. And those of us that are advocates for public health care have been advocating for decades now to extend public health care to cover things like drugs, pharmaceuticals, medically needed pharmaceuticals, like other countries that have public health care systems have coverage for, or elder care in long-term care or in home care, to ensure that as people are moved out of hospitals, they're not moved out from under the umbrella of public Medicare for all and facing the same kind of suffering that, that caused us to create the public healthcare system in the first place. Within this system, of course, healthcare is worth more than $100 billion in Canada. Everywhere in the world it is. It's one of the largest, 40% or so of public budgets, just about everywhere, between 40 and 50%. And so this is a gold mine that for-profit companies would like to mine for their own profit taking. And so there is enormous pressure all the time to privatize both the insured system, that is, do we pay privately or do we have a public healthcare system that covers us? And also who delivers public healthcare. Over the years, we have lost big sections of public healthcare. About 30 years in the 1990s, we had a government called the Harris government that was a very radical government that was intent on shrinking the public sphere and privatizing it. They privatized home care, and it's been a disaster in Ontario ever since. They privatized the majority of long-term care homes, that's nursing homes. And in the pandemic, we saw what happened as a result of that, where for-profit companies literally took tens of millions of dollars per month out in their own profits, while they left their residents to starve. Literally, residents died of starvation, of dehydration. Now, at this point, more than 5,300 have died of COVID alone, a preventable respiratory disease. people died of just total failure to provide the care that they need in facilities that are set up to provide that care, and for which the residents pay co-payments and we pay our taxes to provide that care. They took the money but didn't provide the care, and that continues to this day. Now the Ford government wants to privatize our public hospitals. Since 1973 in this province, private for-profit hospitals have been banned for good reason. The idea is that care should be based on the public interest, not for private interests, not for private for-profit corporations to take as much money out as possible. Where we have seen private for-profit clinics spring up across Canada and start to eat away into our public hospital system, we have seen that they bring with them illegal extra charges for patients that are enormous. You know, we have called from the Ontario Health Coalition all the private clinics in the country twice, and we've called all the private clinics in Ontario 4 times. Each time we posed as patients and we said, listen, we want to buy our way to the front of the line in healthcare. How much do I have to pay? How fast can I get my care? And in each instance, we caught the majority, not a small portion, but the majority of the for-profit clinics extra billing patients. That's illegal. You can't sell queue jumping. You're not allowed to charge a patient for surgery. You're not allowed to do that under the Canada Health Act and under provincial law, but the majority of them do it. And the prices are outrageous. In the eye surgery clinics, for example, they're charging $2,000 per eye for cataract surgeries. Under OHIP, the cost is $500, $505 for cataract surgery. For MRIs and CTs, the prices start at $1,000 for an MRI. Add contrast, it's more money. Add body parts, it's more money. In the public healthcare system, when we ramp up the number of MRIs we do in the public hospitals, it costs $280 to $350 per MRI, less than a third of the cost. For hip and knee surgeries, for a hip replacement surgery, for example, in the public health system, in our public hospitals, it'll cost $3,000 to $8,000 to do that surgery. In the private clinics, they're routinely charging patients $23,000, $25,000, $30,000. I just heard from a patient a few weeks ago, $50,000 for a day hip surgery in a private clinic, many times the cost. And they take the health professionals, the scarce staff, out of our public hospitals to the private clinics, and they only take the profitable surgeries. So they take the easy surgeries, the light patients, the patients who they can move through quickly because profit comes from doing high volumes. And so it's the fast, easy surgeries, the profitable surgeries. But the trick is that those surgeries subsidize the more complex surgeries in our public hospitals. And if you take only the light, easy care patients, the ones who don't have diabetes or aren't obese or don't have COPD and heart arrhythmias and so on, those patients more likely to have high risk surgeries or code on the operating table, right? So they don't take them, they leave them to the public system, but they take the staff and the funding out of the public hospitals, leaving behind the heavier care patients with less staff and less funding to provide for them. And in order to make their profits, they cut corners. They have serious quality problems. The major studies, these are meta-analyses. So they're the studies of all of the existing studies of patients in the United States where they have a private healthcare system. For-profit hospitals versus not-for-profit hospitals. And so the meta-analysis literally looks at millions of patients in thousands of hospitals and found that they have higher death rates, significantly higher death rates in the for-profit hospitals. Why? Because they hire less trained staff than the not-for-profit and public hospitals do. This is the same in our long-term care homes, where they have had 5 times the death rate under COVID of the not-for-profit and publicly owned long-term care homes because they have less staff. In the for-profit hemodialysis clinics, the meta-analyses over 20 years show, again, significantly higher death rates. Why? Because they move the patients through quicker. They clean their blood less in order to save money for their profits. And they have less trained staff than the public or not-for-profit clinics do. And these kinds of quality issues that are serious, I mean, it should be a no-brainer. You hand it over to a for-profit company and they kill more patients unnecessarily than a not-for-profit or a public company. Why would we even ever consider doing that? Right? That alone should kill the idea of for-profit privatization. But they are continuing to do it regardless. Why? Because there's a powerful industry that wants to take profit from our public healthcare system. So we wanted to talk with you tonight about a fight back and about involving students to save our public hospitals. Once they privatize them, once they hand over the ownership to private for-profit companies like home care 25 years ago, like long-term care 25 years ago, you know, it would be almost impossible to get it back. Again, this is your future, our future together, and I hope that you'll get involved. I'm sorry, I didn't realize Anissa has to go very soon, so I'll leave you be for a little bit and then I'll come back, okay? We have 2 public meetings running at the same time.
Hi. Thank you. So I wanted to start with a reflection. I don't need you to raise your hands, or if you don't want to, but I do need you to think about this particular question. How many of you feel that your mental health has deteriorated at any point in the last 3 years? Did you seek help? If you did, was it an easy process? Did you get the help you needed? I ask this because in the past 3 years, we have learned how important our mental health is. During the hard times of the pandemic, so many of us struggle with anxiety, depression, feelings of isolation and despair, and many of us turn to our healthcare system to help us. I'm going to guess that this was not an easy process. You probably encountered many roadblocks like waiting lists, having to pay a lot of money for psychotherapy or counseling, or having access to only 1 or 2 sessions, or if you were in a hospital, you probably had to wait a long time in the ER, sometimes even days, before being admitted to a mental health unit. Then you felt that it didn't help at all because the nurses didn't have time to talk to you. You saw your psychiatrist for 5 minutes. If you were lucky, you were discharged with a referral to a community service. But in most cases, you were just discharged, probably well before you felt ready. If you were one of the lucky ones and had a referral to a community mental health care, you still probably had to wait several months before your intake. I can go on and on and on with all that is wrong with our mental health system right now. I know all the pitfalls because I have been a mental health nurse for over 12 years, and I have worked both in hospital and community settings. Today, I'm going to tell you why it is so difficult for you to get the help you need when you need it. I'm going to start with hospitals. I started my career 12 years ago as a nurse working in a Toronto hospital, and I stayed there for 8 years. It was one of the busiest mental health units in the city. When I started, the nurse to patient ratio, it was 1 nurse for 4 patients, which is in line with the best practices guidelines for acute mental health units all over the world. By the time I left, that's 5 years ago, that ratio had increased to 1 nurse for every 7 patients. Today, it's 1 to 9. I was lucky because when I started, they still had good mentorship programs and a good transfer of knowledge between experienced and new nurses. I was trained by the very best. The very experienced nurse that I learned from, I learned so much from them. Unfortunately, by the time I left 5 years ago, again from the hospital, all those wonderful nurses were gone because they were offered early retirement packages and pretty much forced to leave. The change happened very fast, and there was no time to do a proper transfer of knowledge. They were replaced with very new nurses that neither had experience nor the specific training that a field like mental health requires. Because of this, very few of them stayed in the unit for more than a year. Some of them didn't in the last 6 months. The staff rotation became so bad that we were chronically short-staffed. We weren't able to retain nurses, so they started increasing that nurse-to-patient ratio I talked to you about. Then they stopped even trying to replace those nurses. They just kept that ratio high. The results were catastrophic. The number of medical errors, violence against staff, and other indicators of deteriorations of the quality of care exploded in the last 3 years I was there. It actually became very unsafe. It was a very unsafe place to work in. When I started my career, this particular hospital had an in-house security team. It was a fantastic security team. It was especially trained in something that we call nonviolent de-escalation techniques. They were so good at it. They were better than the nurses and the doctors combined. They were so good at de-escalating patients by just talking to them that the Toronto police asked them to train the first responders officers. But by the time I left, they had decided to tertiarize, which is another fancy word to privatize, the security in the hospital. So very few of those best trained security officers remain. The result, another sky-high increase on violent incidents within the hospital. Just for you to understand how things are for nurses today, let me tell you how was my last shift in this hospital. I was 8 months pregnant, about to go on maternity leave. It was late December, so it was a very busy time in a mental health unit. I had an 8-hour evening shift, like at 3 to 11 p.m. And when I arrived to the unit, I noticed that I had been scheduled mainly with the new nurses. Even our nurse in charge was new. She was very young, recently graduated too. So the shift went back to worse. We ended up having 7 code whites in an 8-hour period. For those of you who don't know what a code white is, it's basically a code that we call when there's an actively aggressive patient in a unit. So the nurses couldn't keep up. We were short 2 nurses. The nurse in charge was very young. They didn't have the proper training, the proper direction. I'm an RPN, but at that time, I was not supposed to be in charge of a unit, nor did I have the training required to do so. But things got so volatile that day that I had to do it. The nurse in charge was in tears, so overwhelmed. And the rest of the team was very scared. They didn't even know how to use the equipment properly, the right protocols to follow, the medications to ask the doctors to order. We had a client so violent that day that it took 5 people to contain him. I was 8 months pregnant. I shouldn't have even close to that situation because the nurses didn't know how to handle it. I was there. I had to help restrain that patient. It was one of the scariest nights of my nursing career, and I decided then and there that I was not coming back from maternity leave. I didn't. And I took a big hit on salary because I lost my seniority, the overtime, the weekend bonuses, and a great pension plan. But it was for me more important to be alive and well to take care of my daughter. I have nurse friends from that hospital that were severely injured. We're not talking about like hair pulling or a black eye. We're talking about a 2nd-degree burn in the face and chest, choking until you pass out, and a broken jaw. That is what nurses in hospitals face every day they go to work. I just want you to understand how it looks like when a vital service has been underfunded and understaffed. That is how it looks like in reality. This is what we nurses have to deal with, all without having received an increase on pay over the rate of inflation in 2 decades. And in the last 3 years, since Bill 124 came into effect, thanks to the Ford government, the increases have been only 1% yearly. The problem didn't start with the current government, that's true, but it has certainly become much worse. Now the short-staffed shifts are the norm, not the exception. Now the push is to discharge a patient as fast as humanly possible to save money, even if that means that this patient will have complications and will likely return in even worse condition. Now we don't even properly train our nurses because we don't have the time. As for community services, things are even worse. We have a severe shortage of nurses and doctors trained in mental health. In certain areas like rural towns, the situation is so dire that their waiting lists are like over 3 years. Just to give you an example, I live in Barrie. The Simcoe County only has 3 active psychiatrists for the entire county. We're talking about 20 towns. 3 doctors serving a population over 500,000 people. This is why you have to wait so long to get an appointment with a psychiatrist in Bari. Counseling and psychotherapy are probably the most important part of the treatment of mental health illnesses. However, they are not covered by OHIP. You have to find your own and pay out of pocket over $100 per consult. If you're lucky, your work insurance will pick up part of that bill. But if you're not, you're on your own. Understaffing and underfunding are problems that can be solved. We can improve the investment levels for our hospitals and our communities. There is just not the political will to do so. And that is the real issue that we're trying to solve. Please join us in this fight because we really need you. Thank you.
Thank you so much, Anissa. Lastly, we're just going to hear from Hisham. Hisham is a member of the Ontario Medical Students Association. So whenever you're ready, Hisham.
Yeah, hi everyone. Thank you all for being here, for taking the time. And thank you to the Ontario Health Coalition for organizing this event tonight. Tremendously important event at a really crucial and critical time. Thank you to the speakers before me for really inspiring speeches as well. So my name's Hisham Shoker. I'm a third-year medical student at Western, so in London, Ontario. And I'm also a part of the Ontario Medical Students Association. So what I'll kind of focus on, I switched my talk a little bit at the last minute, and it's pretty brief actually overall, but what I'll try to focus on is, assuming that we're all kind of in this together, right? And we're going to be, doing what we can over the next little while to make sure that these plans to privatize a lot of the hospital services and surgeries and, a lot of the diagnostic imaging, like all these plans that are part of Bill 60 mainly and beyond that as well. That when we're, talking with our peers, as students in healthcare fields, or when we're talking with our family or friends, and people bring up like certain points, and we know how to respond to them, right? So we know how, what certain key points might be brought up or kind of myths around the topic of privatization, and how to respond to these key points when we're tabling on our campuses or talking with our friends or in class when these issues get brought up, right? So there's three myths that I thought about, and I'm sure that there's others that we could think about together. And the first one is the myth of scarcity, right? So there's this idea that we're really, we have a scarce amount of resources and we need to cut costs from the public system because we're under strain, right? We can't keep funding public hospitals because they're draining our budget. We're simply, we can't afford to keep paying as much as we are for our public healthcare services, right? So we'll often hear this, whether it's in the media or whether, in conversations, right? And so, the answer to that is really that, in fact, it's quite the opposite, right? Ontario has actually chronically underfunded public healthcare, and this issue has gotten significantly worse under the Ford government. So it's in medical terms, like an acute on chronic picture, right? So Ontario is really one of the richest provinces, but in fact, it spends less per person on healthcare than any other province. So adequate funding, so if we were to spend the average of what other provinces spend, would mean being able to hire more nurses and other healthcare professionals, being able to properly pay healthcare professionals, and it would mean opening up the operating rooms that have been closed due to short staffing, and being able to deal with this backlog of surgeries that has now become the excuse for having to think of innovative ways of opening private for-profit clinics, right? So when we hear about this COVID backlog of surgeries and diagnostic imaging, it's often used as an excuse to create private for-profit centers, and we have to remind ourselves that actually, if we're funding our public services adequately and appropriately, then we wouldn't have to, we have the capacity there, right? So data from 2022 to 2023 fiscal year shows that when it comes to overall health budget, our government has underspent by $1.25 billion, less than what was planned. And at the same time, within this underspending, we're actually spending on some of the wrong things. So one area, or a key area of, where we're actually massively overspending is on for-profit clinics. So we're, number one, we're not a poor province. Our government revenue is increasing, is a significant revenue, and it's been increasing over time. And we need to really ask ourselves what our priorities are, right? How can we have increased revenue but decrease spending on healthcare? how can we have a decreased spending on healthcare across the board, with the exception of increasing money that's going to private for-profit clinics? So that's myth number one. The second myth is that we'll hear people say that, well, regardless, what does it matter if I go to a private for-profit surgical center or to a public hospital? Regardless, these services are going to be covered by OHIP, right? And we actually hear Doug Ford say this repeatedly, and the health minister say this repeatedly. Well, you as long as you got your OHIP card, you're good. You won't need to be paying, and there's nothing to worry about, right? So we hear these promises by the provincial government and by our elected officials from the Conservative Party especially. And again, this in reality is actually false, right? So as our speakers outlined, and there is a recent, actually, the Ontario Health Coalition last week published a briefing note, and was collecting stories of dozens and dozens of patients who in the past couple of years have had to go to get diagnostic imaging or surgeries done, all that were medically necessary. And we're paying thousands of dollars for these healthcare services, right? And whether it's through double billing, whether it's through creating kind of additional costs on top of what they'll term as medically necessary, and kind of like playing with like the different names and things that they could bill for, or through other mechanisms. Basically, one way or another, people end up going to these places and paying a lot more. Well, first of all, they're paying money, and they're paying like thousands of dollars, right? Actually, funny enough, the other day I was talking to my mom on the phone, and she was telling me how she went to her family doctor the other day, and family doctor told her that she needs a CT. And he presented her with two options. He said, well, you can either wait for 9 months, or you can pay $1,500 and be expedited to receive a CT in a private diagnostic center in the next 2 weeks, right? So this isn't like the exception. This is what's becoming more common across the province. And obviously, if people are not able to afford these services, they end up waiting for much longer, right? So that's the second myth, that we could just use our OHIP card. The third thing to talk about is I called it the myth of neutrality, right? So oftentimes, especially in students in healthcare fields, we're told that we have to kind of remain diplomatic, that we have to stay neutral, that we have to kind of see both sides of the argument. And this is often true, right? Like when you kind of dealing with, let's say, a patient who's, agitated or irritable, we try to kind of put ourselves in their shoes and understand where they're coming from and things like that. And it's important to try to have that perspective of understanding both sides. But what that leads to is in situations like this, around the topic of privatization, for example, someone might say, oh, well, let's play the devil's advocate, or there must be something good about like why Doug Ford is doing all of these things, or even, a lot of these things started even before him. And it leads to that kind of thinking, right? But I'm encouraging us today to actually think about it as, we're actually on the right side of history and on the right side of this issue. And in fact, like these plans to privatize healthcare, there isn't actually a positive spin or a positive aspect to it, right? And how we should be thinking about this is kind of, if we take a look in, kind of historically, there's been many similar instances, right? There's been, if we think about like the tobacco lobby that was, ran advertisements and had billboards of, telling people that they should be smoking cigarettes. Well, why did that stop? And why are tobacco companies no longer allowed to do that? Because people were opposed to this, and, it wasn't in the general interest of the public for that to occur. And so, through that kind of conflict, eventually, we were able to curb the power of tobacco companies, and they're no longer allowed to have advertisements like that on TV, et cetera, right? Similar thing with like fossil fuel companies, right? So when you think about like students at U of T, for example, who are calling for like divestments from fossil fuel companies, calling for, big banks to remove their funding from fossil fuel companies, it's not really a two-sided story, right? It's the story of actually one group is in the right because they're calling for what's good for everybody, and the other group is really mainly concerned about their profits, right? And so it's a similar approach to the issue of privatization. We have to remind ourselves that we're on the right side here, and the other side, really the main issue for them and main priority is that they're able to accumulate more wealth and more profit. So I hope that's helpful, and I hope that when we're doing this work going forward, we're able to think clearly about this issue and kind of understand that there's going to be key talking points that we hear from the other side, and we're able to actually address these with really evidence that we have on our side, right? So yeah, looking forward to what's ahead and looking forward to working alongside everyone, and yeah, happy to answer any questions that there might be. Yeah, thank you so much again for having me.
Thank you so much, Hisham. So we're going to be moving into an organizing portion where we can see what we can do to actually fight back against that. But before we go into that, I want to ask some questions. And before I do that, I just want to point out that there's been two really good examples in the news about refuting these kinds of myths. The first one is actually France Jalina in the Ontario legislature last week. She used Sudbury North Sciences, the hospital system up there, as an example. She said that the hospital there has 17 operating rooms. They've never actually had the staffing to use all 17 of those those operating rooms. Instead, they have used about 15 of them on the normal basis. They haven't ever used it to its full capacity, even those 15 rooms. Instead, what they do is they get a certain amount of funding that they can perform, say, 15,000 cataract surgeries per year, and that's the funding that they get for that. So there's a very simple solution to this problem. Give them more funding so that they can use all 17 of those operating rooms. We have to remember that these private clinics are not sitting there with health professionals sitting in there waiting to take on this backlog. There is no extra workforce that's sitting in reserve inside of these private clinics. Instead, what will happen is as we give them funding, the staffing will go out of the public hospitals and into these private clinics. And what we saw last week in Ottawa is a prime example of that. Ottawa Hospital had extra operating room time, so they rented it out to for-profit clinics. These for-profit clinics promised that they would provide their own staff. What they actually were doing was approaching the hospital staff in the parking lot and trying to entice them to come in on their weekends and work inside of these hospitals or inside of these operating rooms for the private clinic. There was no extra capacity that this private clinic could provide to fix it. So I think these two stories just in the last week really show that there is no gain to this privatization plan, and we have to do everything we can to stop it. So I see one question in the chat, and I see Natalie's just joined us. So if you have any questions for any of our speakers, I'll just put them, you can put them in the chat or raise your hand, whichever one you prefer. So the first question here is, why is the CMA and the government not opposed to private clinics in the first place? Hisham, do you want to speak on that?
Yeah, sure. I mean, I could kind of speak a little bit about the CMA part, right? So like I'm kind of outlining, hopefully with that third myth example that we talked about, that oftentimes what we see is on one side, a group that is mainly, kind of self-interested and interested in the pursuit of profit. And on the other side, we're kind of, trying to focus on what's best for most people, right? And so, the issue of like physicians, like in Canada, and as I'm eventually like I'm in medical school, and kind of have eventually going to be working as a doctor and stuff, but have encountered this so far in my education. So it's important to think about this, I guess like a bit historically, like physicians haven't always been on the right side of a lot of these issues. In fact, with like the first when Medicare was first going to be implemented across Canada, it was one of the only times in I think one of only 2 times that physicians across Canada went on strike because they were concerned that they wouldn't be getting paid as much under Medicare as opposed to like compared to like private, and they were kind of not really on the right side of this, right? On the other hand, there's other physician groups like the Canadian Doctors for Medicare. I think even the CPSO, the Canadian College of Physicians and Surgeons of Ontario, has come out and spoken out against the privatization plans, right? So that's kind of, I guess, from like the CMA and also like the OMA perspective of why these groups might not really be on the right side, is because they often are kind of representing their members, and like they're often kind of focused on what might be best in terms of like at the end of the day, like their members like maximizing their salaries and things like that, but that might not actually be what's best for people. And that's the case here, I think.
Does that answer your question, or do you have any other questions you'd like to ask?
I could just add one other thing, but on the other hand, we have many other groups, like the largest unions representing healthcare workers in Canada, the CPSO, Canadian Doctors for Medicare. There's many groups who are invested in what's best for the public's health, and they're kind of opposed to these plans. So just to emphasize that.
Yeah. And I think that's an important thing to say. If we are talking to people, oftentimes we hear, oh, the unions just want to support public health care. For some reason, they think unions have some big vested interest in doing that. But the OMA and the CMA, for some reason, are seen as more impartial, which is insane, because it's the CMA and the OMA that stands for profiting for this. Your nurse isn't really going to profit regardless of where they're working. There is no profit motive for these unionized workers to do this. So that's an important myth to also keep in your mind. Does anyone else have any questions before we move into the organizing section of this? Oh, Mandy, is there any particular power or leverage you see students having that other people don't? That's a good question. Does anyone want to speak on this?
I will. I just think that I think the biggest threat to public Medicare in Canada is that we take it for granted. People, generally speaking, don't realize that there really is this set of for-profit interests that pose an existential threat to single-tier public Medicare. And that unless we actually safeguard it from those forces, we will lose it. I think generally speaking, most Canadians think that our governments won't do things that would be incredibly harmful to us, or that they wouldn't privatize public health care, or we wouldn't lose public health care, but we really are losing it bit by bit by bit. And so I think it's critical that this generation, the generation who are students now, really understand what's at stake and are articulate about it and versed in it and understand the history, and also bring your voices about the modernization of public health care to bear. Because if we don't, then it's the generation, mostly in the Health Coalition, it's many people who are 80 years old and older, and they're dying. And when they're gone, we need to make sure that there is there are Canadians people who understand what we risk to lose when we lose public health care, and will safeguard it going into the future. I just think you're critical. The other thing is that the energy and the life of students is particularly important. For an entire generation now, we have been trained into diminished expectations. People think we can't afford things anymore. They really do. Like wealthiest, one of the wealthiest countries when was Canada the wealthiest we ever were? Does anyone know? Riley?
During the pandemic.
2019, start of the pandemic, right? That's the wealthiest we ever have been in history. It wasn't, 1960, 1950. And, we're in a weird economic situation right now around the world. But we're one of the wealthiest countries on earth at one of the wealthiest times in our entire history. Of course, we can afford to take care of one another, and just that beating down of expectations that, somehow we can't dream of a society that is more just, that provides more opportunity, where you don't leave university with massive student debt, where you actually have the ability to buy a house and own a house if you want to in your life. The fact that we have allowed them to chip away at our expectations to such an extent, I think is really damaging. We need to work with young people who haven't had their expectations beaten down, who have some life and some fight in you and are willing to stand up for the kind of society that we need. I think you're critical. Do you bring something that's different? Yes, you absolutely do. Do you have more political clout than a senior? And you know what? When students move en masse, you have revolutions. I mean, it's usually young people that drive them. You change the world, you know, so yes, you actually do. And that's quite sincere.
And I just see there's another question in the chat directed at you, Natalie, and that is, can any of this be argued in the courts, given that most of this goes against the CHA? Or is the act so vague that it leaves room for individual provinces to do whatever they want? What about the fact that regardless of who we voted for, no one voted in favor of this government privatizing healthcare? And they note that the latter question is obviously more rhetorical.
Yeah, no kidding, right? It's outrageous. Well, we will. I mean, we can bring the Quebec. There was like a large seniors organization called the Réseau de something, which I need to memorize because I've forgotten. But it's like it was 500,000 seniors or so in Quebec, which in Quebec is pretty large because they have less population than we do. And they brought a writ of mandamus. It's a legal challenge to force the government to live up to its own legislation. They brought one against the federal government. This is interesting, eh? In Quebec, for the federal government failing to uphold the Canada Health Act and stop the private clinics in Quebec from user fees and extra billing of patients. And as a result, the federal government put pressure on the Quebec government, which is the Legault government, and they brought in a regulation banning what they call ancillary fees, so extra billing of patients. So that lasted for a few years and has kind of fallen away again, because as long as you have private clinics, they will always keep trying. They'll do what they can get away with. That's essentially what happens. So they did do that. We can do that here, and I will do it. We will, if we lose. But the thing is, you only do that after the fact, like once thousands of people are being billed for their healthcare. We actually want to stop them from being able to privatize the ownership of it. There's no law that we can use to stop that. Unfortunately, there is no law that stops a government from lying during an election campaign, which actually happened outright this time, although we have proposed a law to do that. So we have to stop it politically. It has to be through political action, and so our idea was hold a referendum. And for you all, could we do it on campus? I don't know if you've discussed that, but could we do, have some voting stations on campuses before exams over the next few weeks? Could we organize at least a few places on an array of campuses and then could we publicize the heck out of it so people, students get a chance to vote and can help, build the vote to stop the privatization of the hospitals. So that's our plan. I mean, politically, if we are to lose, then, we'll go to trying to stop the private clinics from extra billing patients. But the best way to stop them is to just stop the transfer of the ownership of the public hospitals.
And just before we get into the organizing portion that Natalie was just talking about, we just had one more question, which was, do the medical unions generally support or not support public health care? Natalie, do you want to answer this or do you want me to?
Well, I think like by medical unions, if you mean I think you talked about this, like this Canadian Medical Association, the Ontario Medical Association, but then there's also the nursing union in Ontario, ONA. There's the unions for health professionals, which is mostly the Ontario Public Service Employees Union, or OPSU. There's the unions for the support staff. That would be like Unifor and QP and SEIU, generally speaking. And so all of the unions oppose the privatization of the hospitals, with the exception of the doctors, the OMA, because as Hisham described, I mean, if you're like many doctors support public health care, particularly the doctors, in hospitals and the younger doctors who are pretty grounded in those ethics, around consent and equity and social justice and social inclusion and compassion. But there are an array of particularly specialists, like ophthalmologists who are, if they can bill OHIP and then bill on top, that makes more money for them, like routinely. Like the guy, Mark Cohen, who started LASIK MD in 2004, announced that his doctors we're going to commingle LASIK eye surgery with cataract surgery in order to be able to bill OHIP or the equivalent in their province and bill patients on top, right? That is the formula that maximizes their profit. That is what they'd like to do. A number of them never supported the Canada Health Act, even though, frankly, they have been its prime beneficiaries. You know, their incomes have skyrocketed under public Medicare, but they would like more. They would like to bill OHIP, and they would like to bill patients on top, whatever the market can bear. And so they oppose. Obviously, under public Medicare, they're more regulated. There's oversight. There's, controls on how much they can charge, all of those things. As I say, they're doing very well. They're in the top, 5% of income earners, all of them in the country, but, they want more. And if you look at the United States, their counterparts in the United States are making vastly more, which is what they want.
Thanks. And if you guys are interested as well, sorry, I might butcher your name. Albara has put the Mark Cohen article in there as well that Natalie was referencing, or more information about him anyway. So now, like as Natalie was mentioning, we are going to move into the organizing section. So as she mentioned, we're going to be running a referendum. And I think probably a lot of us don't really understand what a referendum is. So referendum in this case is a citizen-run voting station. So we're going to be running the vote across Ontario. We're going to be having those conversations with our neighbors, our friends, and our families about healthcare privatization, and then we'll be publishing the vote. Ford was only elected with the 18% of the popular vote, and as Natalie mentioned, he lied during the election about healthcare privatization. If we can get 1 million people to say that they don't support this, then he knows that he does not have the mandate to do this. He lied during the campaign, and he doesn't have the vote and support to do this to our healthcare system, which is going to hurt all of us. So before we go in there, I just want to show you guys a quick video that will show you we have actually done this before, and we actually had a win with it. And that was when we were going to have P3 hospitals built across Ontario. For those that don't know, a P3 is a public-private partnership. It's where they contract out a large portion of the building and construction of a new hospital to private companies. And what they want to do is basically privatize as much as they can of that hospital and leave only usually the care in the public hands. So what we did was we had a public referendum in Kingston, and this is a video that just sort of shows you what that looks like. So I'm just going to play that for you quick. It's very, very short.
This looks very much like an election campaign, except it's not. It's a plebiscite vote that's actually citizen-run, not government-run. It's put together by the Ontario Health Coalition, asking citizens if they want a public or private hospital.
Well, the drivers have extra ballots, so if they need more, like if they've run out in their trucks, then I will let them know you guys have some extra.
The phone's been nonstop. People are interested. They want to learn more. They've been very supportive of the campaign. We've had very little people coming in upset about what we're doing.
Well, we're holding a community-wide plebiscite, which is a community-wide vote, like a referendum, only it's organized by a citizens group, by the Kingston Health Coalition, about the future of the new hospital in Kingston, whether it's going to be a public, not-for-profit hospital, or whether it'll be built as a P3, privatized P3 hospital with 30-year-long contracts with a private for-profit multinational consortium.
Some people wonder how this affects healthcare. They say, well, the healthcare system remains public because nurses and doctors will be paid by the government. But the model of the P3 hospital is a step in quite a dangerous direction.
Some of the more conservative members of council have tried to argue that we shouldn't have any role in it as municipal councillors because it's a provincial issue.
So we're very concerned in the city of Kingston about where is the money from our property taxpayers going, and it turns out that it's going to fund a consortium that over time will make 12% on their invested money. So that 12% is, part of that 12% is coming from our property taxpayers.
It's been really positive. It's actually really cool. People are pretty excited, especially when they hear that there's 180 other volunteers out there on the ground doing this as well. It's just such an incredible feeling of solidarity. Everybody, even though they've been out there in the cold for an 8-hour day, they have no problem doing it. They're having fun and having a great time.
It's been very hectic, super hectic. We had 3 volunteers here for most of the day, and we barely had a chance to have a drink of coffee, and we're right here in Tim Hortons, so that just goes to tell you how busy we've been.
All the businesses have just been so warming and welcome to allow us to be able to set up these poles. It's been a great commitment by the businesses here in Kingston.
It was a huge victory, and you talk to people on the street, everybody knows what's happening. It's now become a public issue, and it wasn't 2 months ago. Nobody even knew we were getting a new hospital. So we've elevated the debate and the public sort of discussion and the democracy around this healthcare policy to a level which is phenomenal. That's the value in the sense of validating that whole discussion, all that work that was done. And then as the next step forward, we're going to be able to say to the government and the politicians, this community really cares. We want a public healthcare system.
So that video is obviously a little bit older, but it can really show you the kind of conversations and awareness that it can spread into your community. Not only that, there's so much room for potential media coverage where you can invite people to come when you announce it, when you publish where they're going to be, when you have the results, there's another media hit there. There's also a media hit where you take the ballots to Queen's Park and have them counted there by city officials and retired lawyers and people of the community. So where this is really important is we need to try to get these set up on student campuses. And that's going to take a huge amount of boots on the ground and people working together for that. Each community has their own local coalition that's going to be running this, and they will also support you, and we can also support you centrally. As I said, there was about 95 people registered for this call, and they're in universities and colleges across Ontario. I would say each of the main ones, especially the main schools that have healthcare programs, probably had about 6 people on there. There's a team. There's probably 2 or 3 voting stations right there. Also, because we are now in a digital age, if there isn't the capacity to do a physical ballot, we can also do outreach codes with QR codes, and you can do outreach teams where you go and talk to your students, get them to vote with a QR code while they're standing right there. There's so much room for raising awareness here. You can even talk to your professors, go approach them and see if you can speak to their classes for 5 minutes at the beginning of class, or if you can get them to share a QR code as part of their lectures as well. So I just wanted to put that through there and see what kind of volunteers do we have on this call. I know a lot of people are recording it, but if anyone would want to volunteer to head a team at their school, please write in the chat their name and the school that they're at, and we'll follow up with you. We're going to follow up with you regardless, but if we have any volunteers, that would be excellent. And if we don't have any there, so Hisham's going to head up Western, and I think I saw about 7 people from Western registered for this as well. So Hisham's going to have a good team there. I know we have a whole bunch of U of T students, a whole bunch of TNU students as well. I saw a big group from each of them. Mandy as well from OPIRG. So those of you guys who don't know OPIRG, they're the research group that does progressive research for students. So they're going to be in Guelph. The other thing I wanted to talk to you guys, because obviously I'm a long way from a student now and I'm not as young and not a student, so I don't know. But do you guys have any ideas for how we can best approach students? Jordan and Kingston, close to Queens. I finished at Queens as well. There was a bunch of students from Queens. University of Waterloo, excellent. So we've got a good group of volunteers, and there's a bunch of people who I know couldn't make it. Does anyone have any questions about this idea or any ideas about how to do outreach? Physical ballots would be excellent if we could do that as well. Oh, good. So Olivia will connect you with Mandy at Guelph. The other thing is that it can be so small if you want to do leafleting, or we're going to need boxes for these ballot boxes. So, if you want to go to the LCBO and buy some drinks and donate your boxes and pick them up for ballot boxes. Every little bit helps. It's going to take a huge team to do this. Carlton, we see Genevieve's volunteering in Carlton. That's excellent. Okay, so does anyone have any questions or ideas?
Yeah, I guess one thing we were talking about how to reach out to students. So I feel like a lot of like healthcare programs will have like a centralized like Ontario group, for example. So I know like, for example, nursing has the Nursing Students Organization, I believe it's called, the NSO, and they're associated with the RNAO. So they're like the student wing of the Registered Nurses of Ontario. I mean, medical students have OMSA, and I think that like many like each like healthcare profession students like will have a centralized provincial group. So I'm not sure if that's like one avenue that we could think of as well.
Definitely. And I think we invited quite a few of them for this as well. The other question I have for you is I actually don't know, but looking at your calendars, what would be a good day for us to pick for a student vote? I assume probably not a weekend because we would want to catch students while they're on campus. So when would be a good time, do you think, before exams, or what days would be good that we could actually publish and try to organize for? The commitment to volunteer can be as much as you want. If you want to just volunteer and help, we can connect you and you can just show up on the day of the vote. Or if you want to get more involved and do leafleting, it can be as much. We'll take any help you can give. So Mandy's saying probably not a Monday or a Friday. Does anyone have their student calendar with them that they can take a look? And feel free to just speak, take yourself off mute and talk at this point. And also I wanted to thank Olivia at U of T. That's perfect. We'll connect with you as well. And more help from Western. Fisham will connect you with Victoria and Waterloo as well. And York. See, we have a great group already, and this is only a quarter of the people who registered as well. So this is really, really exciting. Now, if anyone has their calendar, I'm still waiting. Yeah, I see a hand up. Genevieve?
Hi, yeah, so I'm looking at the calendar for Carleton, and our exam period is from April 15th to 27th. And I would agree, we'd want to avoid a Monday or a Friday, so perhaps the Wednesday before exam period.
So maybe like the 5th or the 6th?
Yeah. Okay, yeah, and I see, well, somebody says the 6th, so.
Oh, the last day is the 6th.
Of class, yeah.
Okay, so would that make sense, or like is the last day of class really busy, or is it usually a good time to catch people on campus?
I would imagine, like at least for us, for me, the last week of class is April 11th. So I'm not sure about other institutions, but for us, that would be a good fit.
Okay. Mandy?
Just like the last day of class for us is April 6th, but if people don't have a class on that day, I think they would be less likely to be still around. That's a Thursday. Like, I don't know when other people's exams start, but I'm thinking for Guelph, it might even be better to do it the week before the last week. I haven't been a student in a long time though, so maybe students have a better sense.
Also, I guess too, if we don't want to push it too close to exams when students might be busy studying as well, right? Or even final papers and things like that too, right? The week before their exam period to study. Okay, so would you guys then agree maybe if we did either earlier in that week or the week before even? What if we did the Wednesday and Thursday, March 29th and 30th? That's pretty close though. So can I get a show of hands? Maybe if we go through two options, either the 29th and 30th, or maybe what if we did the 4th and the 5th of April? That's the Tuesday and Wednesday. So if you think we should do the last week of March, raise your hand. Okay, so we've got 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay, so and I think probably the speakers and the non-students are not voting, so I think that's a pretty good consensus. So then let's aim for the 29th, or sorry, let's aim for the 29th and 30th of March. And what we'll do is we'll connect the volunteers here. We'll also send out the follow-up and recording to everyone who registered, and we'll start to connect people who are at the same school and see what volunteers we can get. Also, if you have any ideas, feel free to email us at ohc@simpatico.ca, and we'll support you any way that you can as well. It'd be really good if we can get something going in each of your schools, not just for this referendum, but something that we can keep going on a permanent basis. So it was really nice to meet everyone tonight. Does anyone have any questions before we wrap up, or comments or anything? Yep, Andy.
Sorry if you already mentioned this, but are there like specific like procedures and protocols already set out for how you do a referendum? Like, is it like do people have to, is it like strict in terms of like, I've had your ID and now you get this stamp and you can only vote once, or you folks have done this before, right? So you'll kind of help us?
Yeah, so there's a declaration that people would sign either virtually or in person that says that you are only voting once. And it's just a testament that you're not breaking the rules. Any online voting would have like the CAPTCHAs and the security to keep like any kind of robo voting from happening there as well. And we're also going to offer some training and stuff like that too, for that too. And I just see a question here, and how can you best follow what's going on in the OHC? Well, if you registered, there was an option to keep up to date with this campaign. If you clicked yes, then you will get our emails. You can also find us on our Facebook, Twitter, Instagram. Our website is ontariohealthcoalition.ca, and all of our social media is there as well. We even have a TikTok. It's a little dusty, but we're working on it. So if anyone is really good with social media too, we can use your help TikToking and Reddit and all those things as well. Jordan?
Oh, yeah. Are there leaflets I can go to the website and like print off for, because the weekend after next is going to be like a big St. Patrick's Day weekend in Kingston. And there's going to be like thousands of students coming from different schools and whatnot. So I was wondering if I could print out like a couple hundred copies and maybe, throw them around.
Yeah, that's a really good point, actually. And before we go, I'll actually show you on our website right here. If you scroll down about halfway down the page, there's a sign up to be a public healthcare defender. And if you fill out the information here, it goes into a counter. And this is only one of the forms of this sign up page. The Council of Canadians also is running one too that has thousands of people signed up as well. And if you click here, it will bring you into the information for this campaign. So you can see the printable leaflet is here. And if you just click into it, then it will download the PDF to print. I should point out, though, that we are going to be releasing a new leaflet shortly that's going to have information about the referendum. This one more shows about what we talked about tonight. What is the threat? How does it hurt? How is it going to hurt Ontarians? It's still really, really useful, especially for having those conversations. So if you sign up, that's great. The leaflet is here. There's also a fact sheet, which will go through the basic facts of what happened and how they lied during the election, why we banned private clinics and private hospitals, the information and stats and statistics there. So that's also very useful as well. This probably, I hope, isn't going to impact anyone here, but as Natalie mentioned, we are going to be holding a writ of mandamus for those who have been charged for medically necessary charges. So if you have parents or grandparents who have paid for a cataract surgery or any kind of consultation, they can fill out this survey and get in touch with us, and we're going to start collecting evidence for that. So that's just some of the resources on our website, and they would be pretty useful. Oops, I went back too far. But anyway, so you can see that at ontariohealthcoalition.ca. Thanks, Jordan. And I see, no, Olivia, the referendums are not just happening on campuses. Actually, Olivia, I think you were at U of T, right? If I remember right. I might be wrong.
I'm actually at U of Guelph, and I wanted to make sure actually that in the comments there, I put my partner's email because he's at U of T. But I don't know and he wants to volunteer, but I don't know if this is the best way for him to get in contact is through.
Yes, I got his email down. Thank you, Olivia.
Okay, thanks, Sophia. But
That's
yeah, I'm at Guelph.
That's amazing. So I can just speak for Toronto. I've been helping organize the Toronto Health Coalition. And for example, we've already gotten commitments from the neighborhood community access centers to hold referendums at all their areas. As well, I believe the NDP are offering to do it at their constituency offices, the unions at all of their downtown offices. We've also got a team of about, I would say there's probably about 150 or 200 volunteers who are looking to find stations as well. So it's not just going to be at campuses, and you will get support from your local health coalition. And I know the Guelph Health Coalition is amazing too, so they'll be there to help you as well.
Thanks.
Welcome. And I just see. Oh, excellent. I actually went to Brock Justin as well. Who is the professor that you were thinking of? Oh, sorry. To Brock University as well. I reached out as well to some of my old professors. I think they might be able to help as well. So we've got some great resources already on this call. So I think we have a really good start off here as well, especially considering only a small portion were able to make it tonight. So hopefully we can get something really going on as well. Mindy, that's excellent. Okay, if there isn't any more questions, I'm just going to stop the recording, and then I think we can probably